I was going to show you, this is a little boy that has cerebral palsy, and he is walking with a reverse walker. What would be the advantage of a reverse walker, even for an adult?
Well, it's out of your way.
It's out of your way.
You can sit down.
Some of them you can sit down if they have a seat in them. The main reason why they use them with kids is because it makes them stand up straight. And that's really an advantage for an adult too. They're very bulky for an adult, and I think that's why we don't use it as much. People they're just in the way. But the problem with a walker, a regular walker, is people really develop a lot of hip flexion, even if it's up at the right. You know, they start walking with bent over. And so I really like these, but again, they're pretty bulky, but for kids, this is what you see pretty standardly, especially for cerebral palsy. Cerebral palsy is 1 in 200 children. Damage to the central nervous system during pregnancy or birth or childhood. And the Cerebral Palsy Institute, or whatever it's called, allows that up to 5 years. So the reason being is if there's a child who has a head injury up until maybe in a motor vehicle accident, and they have any kind of any kind of issues, you know, any kind of central nervous system issues, spasticity or anything, they will allow them to be diagnosed as cerebral palsy. And why would that be a good thing? They get services. Cerebral palsy gets a lot of services. So they'll have therapy up until they're 18 years old. And so it allows them to have a diagnosis. That is definitely a lot of research. So they do allow this up to 5 years. It is definitely more common in white populations and more common in males to females. I don't know if you know, but the actual live births is higher, not significantly, in females over males. I don't know if you know that, but male babies, it's not horribly higher, but females are more apt to live. How's that sound? But anyway, cerebral palsy is more common in males. You have 4 types of cerebral palsy. You've got spastic cerebral palsy, apoptoid cerebral palsy, atactic or ataxic. I've always heard it called ataxic cerebral palsy. I'm sorry, 3 types. I think I said 4. And what we normally think of is a spastic cerebral palsy patient, and mainly that's because that's about 70% of the cases. They're the ones that have the spasticity that you see, excessive muscle contractions, muscle weakness, scissor walk. They're the ones, they may be affected in upper extremities, they may be a hemiplegic, a paraplegic, they may even be a triplegic. So they'll have like one arm and both legs or something like that. And so that's pretty much the height, the most common is what we consider is just spastic cerebral palsy. The second is the apoptoid cerebral palsy, and I think this percentage is probably lower now. Apoptoid cerebral palsy mainly occurs because of the birthing process. And so since again they're doing so many more C-sections, apoptoid cerebral palsy has gone down. I rarely see an apoptoid child anymore, so I don't know exactly how high it is. What you see with apoptoid is that when they move, it's in this kind of a pattern. I don't know if you've ever seen somebody like that, but they'll be sitting in a chair and they're literally moving all over the place. And that would be like a quadriplegic. They may just have it on one side again. Normally, apoptoid children have normal intelligence. And so it's just, they do very well in school and things like that. And so it's very interesting. The most interesting thing is when they go to sleep. When they go to sleep, it completely stops all that movement. So you can imagine how much, I mean, they're moving all the time, so they have to really get more energy, and it's just an interesting thing. This little lady actually looks a lot like an apoptoid patient. I haven't seen again an apoptoid patient in a long time. Any questions about that? Anytime you have apoptoid movement, if it's continual movement out of control, that's apoptoid. doesn't matter if it's a CP kid or if it's a head injury patient or whatever, so you need to remember that. An ataxic cerebral palsy patient, they have poor balance, staggering gait, and they crisscross their feet. And normally they're pretty much just involved in the lower extremities. And so I think this is the other 10%. It's not very common. Although 1 year on campus we had 3 ataxic cerebral palsy students here all at one time. They were all 3 of them females. And so it's been a number, about 5 or 6 years ago, but I thought that was real interesting. Okay, there's cerebral palsy. What you're looking at with some of the other problems with it is intellectual disability is only about 40%. So a lot of your CP people are actually fairly normal intelligence. And so don't just assume because they have a lot of spasticity and maybe disorders of speech or whatever that they don't have normal intelligence. A lot of them do have disorders of speech where they have trouble speaking. They have spasticity in their mouth muscles, and so that gives them problems. That's 80%, and then seizure disorders is 25%. And that always causes problems. Seizures are just can cause a lot of damage. Okay, treatment is mainly, you know, just like with any other physical therapy with any child, if you don't have good caregiver follow through, you're wasting your time, and that's the truth. And so you want to observe the child with the caregiver and do a good home program, because if they don't continue through with it through the whole week, you know, seeing them twice a week is just almost a waste of time. This used to really affect us, believe it or not, because we were so limited in physical therapists that if you didn't have good follow through, you would make decisions to see kids who have good parents because you knew you could help them. So you see developmental delays. What you're going to do is evaluate the developmental delays, and you're going to work to improve those. And so when you get into when we get into our pediatric treatment, why is it important to keep kids up developmentally? Why is that an important thing? So they can be independent, but why does it matter if they walk at 1 year instead of 3 years?
All those muscles aren't going to mature as well.
Well, that's true, but actually they have proven that if you can keep a child up fairly close developmentally, that their mental, that they also develop mentally much better. And that's true, really true of Down syndrome children. If they sit up when they're 6 to 8 months old and start crawling pretty much on time and start walking pretty much on time, they do much better mentally. Their disability mentally is not as severe. So you want to keep them up as developmentally, and that's one of the things we'll learn in the pediatric part of it is the developmental levels and you know, when they sit up and when they walk and when they start standing up by themselves and all that stuff. You're going to do a lot of caregiver education, and the other thing that's very true for all CP kids, but all kids, is that when you have low-tone children, they are much more difficult to deal with than high-tone kids. You can decrease spasticity and work around that, but when you got a low-tone kid that just kind of hangs out and has a hard time moving because they're so low-tone, they're much more difficult to deal with. Your Down syndrome children are low-tone until they get up to about 5 or 6 years of age. So they're a little hard to deal with for that matter. Okay, there's cerebral palsy. Developmental delay used to be a very common diagnosis. They try to avoid this now, mainly because it is a kind of a catch-all diagnosis when they don't know what else is going on. And that does happen sometimes with babies that are born and they just are very mentally deficient and just are very slow in development, and there was really no reason that they can find that anything was going on. So it is still kind of a catch-all diagnosis. They have intellectual disability, slow physical development, and a lot of times there's family problems because they don't know what caused it. It's kind of a hard thing when you don't know what causes things. Because what do parents do? They blame each other, don't they? You should have eaten better while you were pregnant. You know, that kind of thing. So they don't know really what happened there. So it's a hard thing if that's the only diagnosis you have. Fetal alcohol syndrome is a very interesting one to look at, and it kind of goes the gamut of just learning disabilities all the way to being very mentally disabled. What happens is the fetal liver is underdeveloped and cannot oxidize the alcohol, and as a result, the fetal brain literally soaks in alcohol until the mother's blood alcohol count drops. The thing about fetal alcohol syndrome too is someone may have only had one night of going out and drinking quite a bit, or even one drink, and it really affected a child. And then you'll have a mom who is an alcoholic throughout that didn't have such a severe effect on the baby. And so these are very difficult babies to deal with. And why? Why is this a difficult situation?
They have withdrawals.
Well, they have withdrawals, but it's always the mama's fault. It's always going to be the mama's fault if that baby that isn't normal. So you're dealing with some family issues that are major.
Do they call CPS on them?
Pardon me?
Do they call CPS on them?
Yes, they would, and especially that I think that they probably put meth babies under fetal alcohol syndrome, because you still see that some. So if there's any kind of drug or alcohol in your system, I believe when you deliver a baby, they're going to do blood work on you. They're going to call DHS. Yeah, they do. As a matter of fact, I'm sure they do. So one of the interesting things about fetal alcohol syndrome is they do have a certain way that they look. You'll see the low nasal bridge where they're kind of flat across the nose. And the other thing that you see are these little, right here on the inside of the eye, they're little flaps that kind of go over. They're called epicantric folds, where you can kind of see the fold in the little boy of the actual picture. They have a short nose, small, mid-face. A lot of times their little chins are different. And also a big one is the thin upper lip. And so these kids both of these kids have the thin upper lip and the folds on the eyes. And this can be any level of severity. I was going to tell you all that, and I may have told y'all this story about my friend Martha Osborne. Y'all know, have you ever heard me tell you about when she did a mission trip to Russia? Have I ever told you this? Well, I wish I had the picture, but she went into Moscow and went to a small village that, it was through the Catholic Church, and went into a small village basically to help these people deal with children who are very developmentally delayed. They took all kinds of equipment in there, and she stayed for 2 weeks. But she took tons of pictures, and everybody in that village had alcohol syndrome, fetal alcohol syndrome. They all had the same look. And so she brought back pictures of parents and children, and they all had fetal alcohol syndrome, which means that they had no prenatal training on you don't drink when you're pregnant. And so it was an interesting thing and very eye-opening to her. It really broke her heart, but it was an interesting thing to look at. So it does make a big difference. The worst damage, of course, would be in the first 3 months of pregnancy. Why? Because that's when your nervous system's developed, isn't it? So a lot of that happens. 20% die in the first few weeks of birth. So you really do lose a lot of them. They have low birth weight, small heads, intellectual disability, learning disabilities, joint problems, heart abnormalities, facial features, small eyes with the vertical skin folds extending from the upper eyelid to the side of the nose, and a small jaw. Newborn babies sleep very poorly, they suck poorly, and they're pretty irritable, is what I understand. I actually have only worked with 1 or 2 babies that had, where it was so obvious in the facial features, but I have a little boy in my family that's about 9, And he has been raised by two grandmothers who are both special ed teachers. So it's been really interesting. He was really a meth baby and was pretty well, not abused, but neglected for the first 6 months of his life. And so once they finally got him, they've been able to do great things, but he definitely has the fetal alcohol syndrome nose and the parts in the eye that we were talking about that extends over, so you can see it in his face. But he's doing very well. He's doing well in school. They've been able to just do some great things with him. But he definitely had a lot of negative things against him when he started. I would say probably the neglect was the main thing that had affected him. He's just now at a point where, for years when I could see him, he never would look me in the eye. And I saw him about 2 weeks ago, and he sat down and had a full conversation with me. So it was really kind of neat to see such a change and for him to be doing so well. It helps to have two grandmas taking care of you that are both do the special ed stuff. Okay. Muscular dystrophy is a very interesting disease, and usually what we deal with is the Duchenne's, a group of hereditary myopathies characterized by progressive muscle weakness, deterioration, and destruction and regeneration of muscle fibers being replaced with fibrous and fatty tissue. And so this is kind of what happens there. The most common that is the DMD is the Duchenne's, and that's where you see the majority of your patients. There's Becker's dystrophy, myotonic, there's limb-girdle dystrophy. These are not as severe, and these people don't normally die. They just deal with different areas of muscle weakness. Facioscapulohumeral weakness, that's one of them. This is also in males and females, where normally Duchenne's is only in males because it is carried on the X chromosome, and if they have two X chromosomes, then a female, it's dominant. She can be a carrier for her children, but for the boys, but so it's carried on the X chromosome, and so that's hard too. And it's not uncommon to see 2 or 3 Duchenne's in one family. That used to be even more common than it is now. I think they do a lot more genetic testing now with people having babies, and once you have one, they kind of tell you that your chances are, well, 100%. If she's a carrier, 100% for their boys, they'll all have muscular dystrophy. Duchenne's leads to total paralysis and early death. It's 33 out of 100,000 live births, which seems really high to me. 1/3 of cases occur in families without any previous history, so it's a mutation gene. So 1/3 of them, kids just have it. Increased recessive X chromosome, they're always males, carried by the mother genetically. Etiology is absence of dystrophin from muscle tissue. And you have cardiac involvement in all cases, and death is usually respiratory failure or secondary to an infection, and it's between the ages of 18 to 25 years of age. Does anybody know anybody with Duchenne's? Yeah. Are they in pretty good shape? Do they have a good family?
Yeah, they do. I think it's a little boy, and I think his sister has it too. So
well, I wondered, it'd be interesting to know what kind she has. She probably has one of these other kinds. Yeah. She can't have this one. But maybe it's, I don't know, maybe it shows up, somehow in that, where it affects her, but probably not as severe.
Yeah, it's not as bad on her.
Yeah.
I saw a Charcot Marie Tooth one at the clinic.
Oh, you did?
Mm-hmm. She was interesting.
I worked with a family that had that in their family. The mother had it, and then the daughter had it. The daughter was a complete quadriplegic by the time she was probably 10 years old. The mother was in a wheelchair, but she was still partly ambulatory and could stand. So that one's kind of a weird, why it's so severe in some cases and not in others. This girl did end up dying. She was about 22 when she died. They had the quadriplegic, and so it was a sad thing. It was in a family that was. How severe was that one, Charcot?
she still had her arms, but
Okay.
she, her legs were just
So
so
she was in a
just,
wheelchair.
yeah.
How old was she?
I think she was in her 20s,
Okay.
but I'm pretty sure her parents have it, and she decided she's not having kids because they would end up with it, and
Mhm.
she just,
Yeah. I don't know exactly how that's genetically goes down the line, but it's definitely a genetic thing. Both parents have it, is that what you said?
I think that's what she said.
Wow. Okay.
That's sad.
Yeah, it is sad. These cases are real sad too. Mainly what I've done with muscular dystrophy is get equipment for them. And the most important thing, remember, with any patient, when you put them in a wheelchair, make sure you keep shoes on them, because if they ever lose that dorsiflexion where you can put their feet flat on a footrest, putting them in a wheelchair is very difficult. Very difficult. Symptoms do appear between 2 to 5 years. They have deep tendon reflexes absent by 8 to 10 years. Sensation is normal. Weakness develops proximally to distally. So they get where they can't use their shoulders, but they do this. So they go work from their elbows, like a shoulder patient's what they do. In bowel and bladder function is usually spared. Years ago, Bill we didn't have good handicap, our bathrooms were horrible. Bill, I think, was partly involved with taking this young man that was in an electric chair, and I think they helped him toilet because he had to literally be picked up and put on the toilet, and so they had that set up because it wasn't available for him here. But they do have normal bowel and bladder function. Age 12 is the typical age that they stop being able to walk, because they develop such a forward tummy and their legs are getting so weak, and so around 12 is when they aren't able to walk. This is called the Gower sign. You see this very early. Normally this is the first thing you're going to see in these kids that are 3 to 5 years old. And instead of coming up like a normal child, they'll come up on their knees and lock their knees in, and then come up on all fours and then push up like that, which would be very abnormal for a kid that, they're just already showing weakness in their lower extremities, and that's called a Gower sign.
So they, like, whenever, because you said that they don't live till like their late 20s or so, and does the weakness just like get to the diaphragm and they can't breathe? Or?
Yes, it eventually gets to the diaphragm. And again, they have to decide whether they're going on a respirator or not. Many of them do not.
So they have to like slowly suffocate. That's awful.
Yeah, it's a slow process. This is one that's really awful.
What is the Gower sign?
It's where they push up like those little boys are doing, and it happens when, think about how a normal 3-year-old gets up. They almost just stand up without even, they'll come up, they don't even come up on their knees like you do, they just kind of come straight up. These little boys have to push up, they start, and they come up with their knees and they lock in their knees, and then they'll have their hands down and they'll start kind of pushing themselves up like that, so they're very weak. We'll start to see that would be a very abnormal way for them to come up. I saw a little boy do this years ago in an airport. I didn't say a word, because I don't know that they knew, and I remember seeing that. Okay, here's a family that has the Duchenne's, and so here's 2 little boys that have it. So again, it's real common for there to be more than one in a family.
That's almost like, I feel like evil.
Evil?
Yeah, like you find out, like why would you continue to have kids?
Well, this is probably years ago when birth control wasn't as good as it is now.
Yeah.
So I think a lot of it is that happened, and then they didn't, abortion, people don't abort, so I don't know, it's, at this point, it would be a hard thing to do it, because once I'm pretty sure it's 100% in all the boys if the mother's a carrier, so. Okay, trisomy 18 is Edwards syndrome, and you do see these kids a little bit, they're very severe. 1 in 8,000 live births, females are 3 to 1 to males. There's an increase, you know, anytime you have a genetic thing with an increase in the maternal age, you have more possibilities. Down syndrome is that way. Trisomy 18 is that way. 10% of these kids survive past, actually most of them die in the womb. They don't ever make it to birth. So many of them die in the womb. Or they die that first year. I've actually had contact with 2 of these babies in my lifetime. One of them was born to a very young family. It was their first baby, and that baby lived till he was about 8 months old. Had definitely the features. And then I had a friend who had carried a baby for about 8 months in the womb, and the baby died in the womb. And so that's just kind of what happens with these kids. But you will see them. Sometimes they live, and you see them. Serious organic malformations like organs, that's talking about organs, cardiovascular problems, urogenital issues. They have low birth weight, small stature, long narrow skull, low set ears. I may have a picture. I can't remember if I put a picture in here or not. Flexion deformities of the fingers, and their little feet are rocker bottom. So they're kind of like this, their feet are like this, and they look like rocker bottom. So sometimes they don't walk because of that. They have profound mental disabilities, and they are hypotonic initially, so again, that's hard to work with. And then if they live to 5 or 6 years old, they become hypertonic. And so it becomes spasticity in them. So they're just a real interesting child who normally does not walk. Normally they don't walk. Some of the things that you watch, I do have pictures. I'll show you here in just a minute. Actually, I have a picture of one little boy who lived. You have scoliosis, you have limited hip abduction, poor sucking, and then the flexion contractures in the fingers cause a lot of problems. Here's a little boy, yes, I don't have a little boy, wait a sec, that has it. You can see how the head is shaped, and see how flat their little noses are. This, I believe this is the same child. So their heads are flat. See how these look about the same. They're pretty sick. Again, most of them, if they live past that first year, it's rare. So they just have a lot of issues. But you might see them in the clinic because some of them do live. Okay, so that's all the pediatric stuff that we're going to do. You're going to find, like when y'all go, if some of you are doing pediatric clinicals, you are going to see 100 different diagnoses. So if you have a new diagnosis that I haven't covered, these are just kind of the ones we see the most. We will, you know what I don't have in here is Down syndrome. Have I covered Down syndrome before? Well, we'll have to do it. I pull it out. I've got it in there. So we'll put Down syndrome in. What we'll do on Thursday is look at a few more neurological diseases that we haven't covered yet, and then we'll be done with this class for finals next week. Okay.